slide. The next one. Maculopathy. When the macula is affected, you know, macula is the top notch center of vision, isn't it? If your macula is not working properly, you can't see. That clear center of vision is gone, it means. So maculopathy, yes.
She would do anything for her children. And I love my wife and my children very much. I can't bear to see them suffer. And I've tried to.
Can we proceed? Maculopathy, types of maculopathy can be focal, exudative, diffuse, exudative, can be ischemic or a mixture. What is focal exudative maculopathy? What is here is the foveal, there is focal foveal thickening associated with perifoveal hard exudates at the center. That's the fovea is the most critical area for vision. Once there is thickening because of the edema, that is what we're referring to as the maculopathy, focal exudative maculopathy. The edema is woosed and tends to be a bit elevated, and the vision goes down. Although that's the critical center where you are supposed to have tip-top vision. But once edema, once the fluid goes there, and this fluid is coming from the leakage, from the proliferative vessels, once that gets into the macular area, your vision goes down. So focal exudative, focal foveal thickening associated with the perifoveal hard exudates. Fluorescein angiography shows late focal hyperfluorescence due to leakage. Fluorescein angiography, this is an investigation they do to see how the vessels are arranged around the fovea. They will inject the fluorescein, then once that fluorescein eventually gets into the eye, they are able to take the pictures. And it shows clearly the outline of those small vessels around the macula or around the fovea. If those small vessels are not there, they are absent, it means there are no small vessels there. This is ischemic maculopathy. If they are there, they will show the leakage from the dye you have injected. If there is any leakage, it will show the leakage of the fluid around the macula with no problem. So diffuse exudative maculopathy, you have diffuse foveal thickening. Fluorescein angiography shows diffuse hyperfluorescence. The hyperfluorescence is because now that dye you pushed in is leaking around the fovea. In ischemic maculopathy, you have relatively normal fovea on fundoscopy, but the fluorescein angiography shows capillary non-perfusion. The capillaries are not reaching the central part. So you do your fluorescein angiography, the outline of the capillaries are not there around on the fovea. And this is what we are referring to as the ischemic maculopathy. There is ischemia, no fluid is arriving there. And you can have a mixed maculopathy, where there is exudative, diffuse, you can have a mixture like that. That you only know when you do your fluorescein angiography investigation. It's not just about doing a fundoscopy, but no, there is a ischemic maculopathy, no. Ischemic maculopathy will only show once you do a fluorescein angiography, because the small blood vessels will be absent around there. They are blocked. That's why we're referring to it as ischemia. Clinically significant macular edema. This is a terminology you hear in ophthalmology a lot. Clinically significant macular edema is retinal edema within 500 micrometers of the center of the fovea. Hard exudates within 500 micrometers of the center of the fovea if associated with adjacent edema, which may be outside the 500 millimeters mercury, micrometers. In fact, it's not millimeters, micrometers limit. Retinal edema, one disc area is 1,500 micrometers or larger, any part of which is within one disc diameter. This is actually the definition of clinically significant macular edema. I would urge you to read it seriously and memorize it if you can. Treatment: focal maculopathy is focal laser burns to put gentle whitening on the center of the rings. They are small, what we call focal maculopathy. You use laser, you burn those out. No problem. Laser settings, 50 to 100 micrometers beam, 0 to 0.1 second frequency. These are things you learn as you stay in the department. The seniors will be doing this. Eventually, you'll also be a senior. One day, you'll be doing the same things. Diffuse maculopathy, you treat by grid laser treatment. You make like a grid, but it points 1, 2, 3, 4, then 1, 2, 3, 4, like that. Just got a grid, so that the whole area is treated. Maculopathy, poor prognostic factors are things like hard exudates involving the fovea, cystoid macular edema, or mixed exudates with ischemic maculopathy, severe retinopathy at presentation. These are signs not very good for the patient. Classification of diabetic retinopathy, what we've been talking about there is maculopathy. Now let's go to classification of diabetic retinopathy. All clinical lesions, you start with pre-proliferative diabetic retinopathy. All clinical lesions are caused by retinal ischemia. Vascular changes, you have venous changes like beading. Beading, you look at some of the vessels, they are dilated, constricted, dilated, constricted. That's what is called beading. Like beads, those who thread beads. Or sausage-like sedimentation. You know, a sausage, they die in between. Arterioles are narrowed equally, and you can have dark blot hemorrhages, patches of hemorrhages which are dark. Hemorrhagic retinal infarcts or multiple cotton wool spots, small white cotton wool spots. These multiple cotton wool spots are caused by capillary occlusion in the nerve fiber layer. Intraretinal microvascular abnormalities may occur also. I will explain about that. Management should be watched closely. Significant number develop proliferative retinopathy. Welcome, Prof. Proliferative diabetic retinopathy affects 5 to 10% of diabetics. But my opinion is, my bad opinion is that it may be more than 10% in places like Zambia where we don't have all the facilities available. These are percentages quoted in UK where literally you can walk in an eye clinic every day. Here sometimes it's difficult. Patients who are insulin dependent are at increased risk of developing diabetic retinopathy. 60% in 30 years will develop that. Okay. What? 18 slides. Oh, good. Features. Wait. Yeah. When we say features, we're talking of features of proliferative diabetic retinopathy. There's neovascularization, formation of new vessels, vitreous hemorrhage, or generally hemorrhage on the retina. Neovascularization, formation of new vessels. New vessels can occur on the optic disc, and you refer to that as the new vessels on the disc, or NVD, which occur anywhere on the, or can occur anywhere on the retina. You refer to that as new vessels elsewhere, NVE. So this nomenclature of NVD and NVE, you hear about it a lot. It simply means new vessels on the disc or new vessels elsewhere on the retina. Over 1/4 of the retina has to be non-perfused before new vessels appear. So if a patient has developed new vessels, it means over 1/4 of the whole retina is non-perfused. It's not receiving blood nutrients properly. To develop that, there is first non-perfusion. New vessels start as endothelial proliferations arising mainly from the veins. Then they pass through the defects in the internal limiting membrane into the potential vitreoretinal space. Okay. So the mesenchyme from which the new vessels are derived is also the source of fibroblasts. Fibroblasts, which forms what? Fibrous tissue. And these fibrous tissue envelop the new vessels, forming epiretinal membranes. Come on, question? Coming in. Coming in. Coming in. Some will come in when I'm getting out. Vitreous detachment, usually due to traction on the retina. Also have hemorrhages or occurs from the new vessels. Advanced diabetic management. Management of the new vessels and vitreous detachment. Okay. Pan-retinal photocoagulation for the new vessels. Laser settings, these are the laser settings they use. Those new vessels have to be ablated. They get cleared with laser pens using a fundoscopy lens on the slit lamp with that laser thing there. Signs of involution after treatment, you have regression of the new vessels, leaving only ghost vessels. Ghost vessels, white patterns, but no blood vessel inside. Those are the ghosts. And you have a decrease in venous dilatation or absorption of the retinal hemorrhages, and disc becomes pale. These are signs to show that there is progress after the treatment. Advanced diabetic eye disease, you get retinal hemorrhages, intraocular hemorrhages, intraocular going into the vitreous, retrohyaloid hemorrhages or both. Any of these can occur. You can also have tractional retinal detachment because of the pulling away onto the retina. Membranes start pulling out. You have tractional retinal detachment or back membranes. Diabetic maculopathy definition: involvement of the fovea by edema, hard exudates, or ischemia. If the fovea is involved, it means that tip-top vision goes. The center part, the most sensitive part, it means it's gone. So you can have edema, fovea of the edema, there's a fluid there, you have hard exudates there, or ischemia. You can have exudative maculopathy, focal foveal thickening associated with perifoveal hard exudates can occur. Diffuse maculopathy, diffused focal thickening associated with macular edema occurs, or ischemic maculopathy where there is capillary non-perfusion. So you cannot tell that this is ischemic maculopathy by simply doing a fundoscopy. This has to come with a fluorescein angiography, which outlines the small blood vessels. You will see that there are no vessels around on the macula, on the fovea. That's when you can say this is non-perfusion. Without fluorescein angiography, you can't just make out that no, this is fluorescein, there is ischemic maculopathy. No. Questions, ladies and gentlemen? Go ahead. Oh, asking questions? No questions. Eh? We look at pathogenesis. Okay, pathogenesis of diabetic retinopathy. There's no problem. How many slides are these? 10. 10, okay, good. Diabetic retinopathy prevalence, about 40% of cases of diabetes will get that, about. Maybe it could be higher in Africa because to have this, maybe failing treatment. Where they have no treatment, the percentage will be higher. More common in type 1 diabetes mellitus than in type 2. And the proliferative diabetic retinopathy affects 5 to 10% of diabetic population. Type 1 diabetes are at particular risk, and about 60% after 30 years. I think these figures could be higher where you don't have proper facilities, obviously. This book was written in UK where they have good facilities. If you came to Africa, I think like in Zambia, we could have more than this percentage. My guess may be wrong. Risk factors. The duration of diabetes is an important factor here. Most important risk factor. The more you stay with diabetes, especially uncontrolled diabetes, the higher the chances that you are going to have diabetic retinopathy. Uncontrolled. So if you casually, just know that eventually you will be there with diabetic retinopathy. Patients should be advised accordingly. Or question. duration, risk factors, duration is an important factor, most important in fact. Diabetic retinopathy rarely develops within 5 years of the onset of diabetes or before puberty. Duration of diabetes is a stronger predictor for proliferative disease than for maculopathy. Poor control of diabetes, I think this one is the commonest in most countries. Even in UK, I stayed there quite a number of years. You know, you can't have a disease where you have to take treatment every day. People get fed up sometimes. And the poor control is very common even there. Whereas here, the control, not only because you might be wanting control, the drugs are not available. Or people haven't explained the seriousness of the issue. Poor control of diabetes, type 1 diabetic, glucose control can prevent or delay the development or progression of diabetic retinopathy. Can prevent. It's not treatment that once you are on it, they can communicate diabetic retinopathy. Type 1 patients appear to get greater benefit from good control than those with type 2 diabetes. And raised HbA1c is associated with increased risk of proliferative disease. This is hemoglobin A1c. Pregnancy associated with rapid progression of diabetic retinopathy. So ladies who are diabetic, once they get, you know, in this way, and especially with casual control, just know that there will be progression of diabetic retinopathy. Pre-pregnancy severity of retinopathy, especially the presence of the following features. Let me just explain properly. Pregnancy associated with rapid progression of diabetic retinopathy, especially in the presence of the following features, where there is pre-pregnancy severity of retinopathy. Even before they had the pregnancy, they had this. Once they get the pregnancy, it is now getting worse. Poor pre-pregnancy control of diabetes. Development of pre-eclampsia or fluid imbalance. All these are features which enhance the chances of progression of diabetic retinopathy. Hypertension, very common in type 2 diabetes and should be controlled. Diet control is beneficial in type 2 diabetes with maculopathy. I think this one I agree. I'm type 2 diabetic, and so far I'm managing. I'm managing with the BP control, no problem. Nephropathy, severe, is associated with a worsening of diabetic retinopathy. Those who have got kidney problems. Treatment of renal disease leads to improvement of the retinopathy. Other risk factors you see, hyperlipidemia, smoking, cataract surgery, obesity, and anemia. All these are risk factors to getting diabetic retinopathy. How come? Pathogenesis should have come first. Oh, up to 10, okay. This should have been first. Let's look briefly at the pathogenesis of diabetic retinopathy. Predominantly affects small vessels, microangiopathy, in which small blood vessels are vulnerable to damage from hyperglycemia. Small blood vessels. One, the cellular damage mechanism is due to intracellular sorbitol accumulation, this substance called sorbitol. You have accumulation of sorbitol within the tissues. Oxidative stress due to free radicals excess in tissues, and accumulation of advanced glycation end products. These end products in the metabolism of the sugars. Okay? Excessive activation of several protein kinases, kinase C isomes, and disruption of ion channel function is an important early feature. I think the best summary would say poor control, basically. Not listening to what the people are advising you as logical, you take your own logic, is what leads to early appearance of this problem. Serious problem. It's a very serious problem. Can lead to blindness. I think if we told our patients like that, they might be maybe a bit more serious. Capillary pathology is characterized by death of the pericytes. These are cells which wrap the column of endothelial cells, making a column. You have cells outside which are called the pericytes. So these pericytes die, thickening of capillary basement membrane, and the loss of the vascular smooth muscle cells. You are going to have also proliferation of endothelial cells. Hematological changes, abnormalities of erythrocytes, which are red blood cells, leukocytes, white blood cells occur, leading to poor oxygen carrying by the red blood cells. Increase the platelet thickness, increase the plasma viscosity. Note these changes lead to occlusion of those small capillaries and non-perfusion of tissues supplied by the capillaries. Okay. Ladies and gentlemen, questions? They are comfortable.
Maybe after finishing this,
Why I'm asking? Because if you wait after finishing, they will not even remember what. Okay, neovascularization. This is formation of new vessels, new abnormal vessels. You know, the new normal vessels are formed when you are growing up like that, but these are new abnormal vessels. Caused by capillary non-perfusion, which leads to retinal hypoxia. This may progress to neovascularization, extending pre-retinally and intraretinally, going into the retina. Intraretinal microvascular abnormalities do occur. These are shunts that run within the retina from arteries to the from arterioles to the venules, those small arterioles to the venules, in an attempt to revascularize the hypoxic area. These are the new vessels. Vessel growth is thought to be caused by imbalance between the production of angiogenic and anti-angiogenic factors in an attempt to revascularize the hypoxic retina. What is there is an imbalance. Once there is an attempt to revascularize, to push in blood vessels in the hypoxic retina. So once there is an imbalance, you find more vessels are formed there. And those are what they are referring to as neovascularization. Angiogenic factors, vessel growth promotive factors are things like vascular endothelial growth factor, A and F, platelet-derived growth factor, hepatocyte growth factor. These promote vessel growth. Anti-angiogenic factors are things like vessel growth inhibiting factors are endostatin, angiostatin, and pigment epithelium derived factor. These they stop growth of the factors. The other ones here, angiogenic factors, they promote growth of the blood vessels. I think the key determinant or the key factor of the activity of retinopathy is the net balance between vascular endothelial growth factor and endostatin. They play a role. Amen. Amen. Ladies and gentlemen, any questions, please? You are recording this? Okay. You will receive the lecture with the audio complete as usual. And if there are any questions, once you are at home, you read, you are free to come and ask anytime, as long as I'm around. This is the England time, 11. Zambia. Oh. One more?
One more.
No, my 48 slides here.
Good morning, Doc.
Good morning, Mami.
I was kindly asking if you can explain a bit on the previous lecture we had on the treatment of diabetes retinopathy.
Sorry, say again. Take it easy, go slowly so that I can hear as well.
I was kindly asking if you can explain a bit on the treatment of diabetic retinopathy on the previous lecture we had. Hello?
I'm with you.
Did you get my question?
Retinopathy. Once the new blood vessels have formed, the treatment is laser photocoagulation or photoablation. Those new vessels, they cannot go with any treatment, with any drug. You have to use laser to clear them.
Okay. Okay, thank you.
The best treatment is to be sincere with the medication before the new vessels form. Once they form, I'm not sure a lot of people would have laser treatment in Zambia. Maybe those in Lusaka might have. Any other question, please? Any questions, ladies and gentlemen?
Miriam,
Yes, Sunny.
are you okay?
Very much okay.
Okay.
That's it.
That's
Generally okay. Okay. I'm happy if people are okay.
I'll make it for
We should be okay after all. All the lecture, all the time we've wasted here, we should end up being okay. No, my advice to you, all of you, get a textbook, go through the lectures, and the lecture which I've just taken. We've got slides, we've got the audio attached to it, and look at what the textbook has got. It's the same. Take your time, read it through slowly. If there are still any questions, you are free to come tomorrow when I'm here. You can come and ask and clarify the points. Time to clarify points is now, because time for me to examine you will come later. That will be too late for you. I'm hoping that by the time such a time comes, everyone is happy with what they've heard and what they've learned.
There's one more question.
Yes, there's one more question here.
What is pre-eclampsia?
Pre-eclampsia. This is a disease in expecting ladies. Okay. Pre-eclampsia in expecting mothers. Kwantinene kuda kundwa nekumaleba wadi kuda. Eko yaba. Who is asking?
That's only.
It's a lady. Okay.
That's Fiamvika.
Fiamvika? Oh, okay. We are happy. I'm happy. I mean, if everyone is saying Fiamvika, I'm happy. So tomorrow, which topic do we tackle? Sometimes it's better to tell them tomorrow lecture cover on this. So others can read it through before the lecture. When they come, they are okay.
So someone was answering her concerning pre-eclampsia.
I think
So it's a potentially dangerous pregnancy complication.
Yes.
Characterized by high
Blood pressure. It is.